Okay, so well done for getting this far. We've went through pharmacology, we've went through applied pharmacology, we've talked a little bit about the legalities of the drugs that we give. So it's time to take a little bit of a step back and think about the drugs that we are going to carry as Scottish Ambulance Service paramedics. Now, this is where there's a little bit of a conflict because this programme prepares you as an undergraduate student of healthcare profession to be a paramedic, but because it's an occupational programme, we're also preparing you for practice within the Scottish Ambulance Service. So all the drugs that you use as a paramedic, aside from the general meds pouch, are going to come in these two pouches here, the Paramedic Medicines pouch and the cardiac arrest pouch. We also have controlled drugs that are kept in the safe, but we'll cover those later on. So we're going to talk through the drugs that we have in the bag, in the vehicle, the drugs that we have available to us through PGD, through our GR Calc and our medicines exemptions. We'll go through them and we'll look at their mechanism of action and how they work. The specific legalities of how we give drugs and then the application to practice is covered in part 2. So you're going to get that in clinical skills, you're going to get it in patient assessment. So I'm not going to labour the actual how and why of when we use these drugs. So don't worry too much if by the end of part 1 you go, wait a minute, nobody's actually told me that I give amiodarone after the 3rd shot. We're not going to worry about that for now. That's something that we'll look at in the future. At the moment, we really are just concerned with how the drugs physically work, their contraindications, their actions, so we can understand a little bit more about the pharmacology of drugs that we're given. So we're going to tear these bags apart a little bit. So let's get into that. So I don't mean to completely patronise you with this content. You know that we have 2 pouches kept in the bag, one titled Cardiac Arrest and one titled Paramedic Medicines. So you'll find all the medicines that are available to us in these pouches, again, apart from the controlled drugs which are kept in the safe. Now, just like with any medicine, we can look at the date that is on the outside of these pouches, and we can look at the tag to say that they've been sealed, but we still need to check that the drugs are of good presentation, that they're the correct presentation within the pouches, and that they're in date individually, because you cannot rely on that date on the outside of the pouch. So this arrest pouch then will contain 4 or 5 syringes of adrenaline, 1 in 10,000, for injection. And this is what the syringe looks like. Now, if you've not looked at these before, take the opportunity the next time you get the chance to look at the pre-filled syringes. So they contain 1 milligram of adrenaline in 10 mils. That's the 1 in 10,000 concentration. So different to the 1 in 1,000 that you would give for anaphylaxis or life-threatening asthma. And this is for use in cardiac arrest. So what is adrenaline? Well, it's a vasopressor, it's a positive chronotropic agent, it has loads of adrenergic effects, and we give it in cardiac arrest to try and improve cardiac output, provide a bit of squeeze, provide a bit of chronotropy. So that's why we carry that. You will then find 1 pre-filled syringe of amiodarone. This is 30 milligrams per mil, so a total of 300 milligrams in 10 mils. And this is to be given after the 3rd shock in VF or VT arrest, so shockable rhythm arrests. Now, I'm just going to show you a little tip here, not to tread on clinical skills or PA's toes, but if you want to drop small doses of these drugs, for example, for pediatric patients, then you can use a 3-way tap to do this really effectively. So get a smaller syringe, attach it to the larger syringe using a 3-way tap, and then you can quite easily exchange fluid from the larger syringe into the smaller syringe. So this is a perfect way of being really exact about your drug doses, and we're going to do this loads when it comes to part 2. So what is amiodarone? Well, it is an antiarrhythmic drug, so we're going to give it in VT, pulseless VT, or in VF arrest to try and suppress the cardiac arrhythmia. This comes in a pre-filled syringe. It also comes in a single vial. Now, there'll usually be 1 or 2 vials in here. This says 1 vial of 150 and 3, but you can see that there's quite a few in here. This is for training. Now, you may be expected to draw the amiodarone from a vial. The reason that we keep the vial is this is for the 2nd dose. So the 1st dose is 300 and the 2nd dose is 150. But be aware that if the pre-filled syringes are out of stock, you may just get the vial. So this is what I'm talking about in terms of being familiar with the presentations. You might need to draw this up to the same concentration as the pre-filled syringe. And if you think about that, this is 150 milligrams in 3 mils. So if you draw up 2 of these, you'll have 300 milligrams in 6 mils. So how are we going to get that to 30 milligrams per mil? Well, we'd have to dilute it up to 10 mils if that's what you wanted to do. So all questions to think about, all right? So that's our cardiac arrest pouch. Then we move on to the paramedic meds pouch. This is where you're going to find the bulk of medications that we might give in our daily duties. Now, there's a smattering of different presentations in here. Like I say, this can change on a daily basis, but you'll find a mixture of a couple of pre-filled syringes, some tablets, some powders for reconstitution. So first off, we have cefataxime, which is a powdered drug. This is given under PGD, so you'll find the PGD in the app, and there are different presentations. So this is the 1 gram vial powder for reconstitution, and it comes with water for injections that you can use for reconstituting it. We'll talk about the specific preparation again in part 2. The cefataxime is a antibiotic, just like benzyl penicillin, and we'll use this as an alternative to benzyl penicillin when the patient is allergic. The same with Ben-Pen. Obviously, we're not going to give this in patients that are allergic to penicillins, but these are both broad-spectrum antibiotics to be given in sepsis patients or in patients where you suspect meningococcal septicemia. Then we have dexamethasone, 10 soluble tablets. This comes 2 milligrams, and this is for mild, moderate, or severe croup. So dexamethasone, it's a steroid. This is a dissolvable tablet, so you need to mix it with water for injection, 5 to 10 mils, and then you can give it orally. Then we have misoprostol. This, again, it comes in tablet formulation. This is for postpartum hemorrhage within 24 hours of birth, where bleeding from the uterus is uncontrollable by uterine massage. Now, we don't carry symptometrin, so misoprostol is the next best option we have, and it is a uterotonic drug. We can give it orally, or we can give it rectally. Then we have ondansetron. This is obviously an antiemetic drug. This comes in 8 milligrams, in 4 mils, but like I say, it can come in different presentations, and it is for the prevention and treatment of opiate-induced nausea and vomiting and generalized nausea and vomiting. We give this by slow IV injection over 2 minutes. All the instructions for this you will find in GR Calc. This is an exemption medication, and you should usually find that there's 5 of those in each paramedic pouch. Then we have chlorphenamine. This is for severe allergic reactions or for symptomatic allergic reactions that are not quite anaphylaxis. So with an anaphylactic patient, you might put this a little bit further down the line because antihistamines come secondary after things like adrenaline. Then we have tranexamic acid. This is for hemorrhage patients. Now, the criteria for this changes quite frequently, so you can see that it's a GR Calc guideline that I've displayed here, but actually tranexamic acid is given under PGD, so consult the most up-to-date PGD for indications for tranexamic acid. Then we have atropine sulfate. This is 1 milligram in 5 mils. The standard dose is usually a dose of 300 micrograms. But again, we will discuss different doses we can give in part 2. So this is 0.2 milligrams per mil, so a total of 5 mils. Pre-filled syringe, easy peasy. We give this for symptomatic bradycardia. So these are the drugs that we have in the pouches. No more complicated than that. We very briefly, because it turns out that I recorded this video and I really went through it at some pace, we've very briefly talked about the indications or what the drugs are used for. So let's pick a couple and look at them in a little bit more detail. And then I'll give you guys some to look at yourselves, and you can post what you think on the Padlet wall. So let's pick a drug to begin with and look at the mechanism of action. So how about looking at a drug from this pouch? Let's have a look here. So here we have a paramedic pouch. I would point out that the majority of paramedic pouches are a lot neater than this, but this is a training only pouch. So let's open this up and we'll pick a drug out here, and let's just have a look at tranexamic acid for starters. So tranexamic acid, single vials, 1 dose is a gram, so 500 milligrams in 5 mils. So a full dose will be 2 of these vials for an adult, or it might be less for a child. But again, we don't care about dosing. Let's talk about TXA, tranexamic acid. What is it? Well, it's an antifibrinolytic, and it was discovered in the 60s, actually, but in the last few years, it's seen this renewed interest because it is actually very good at managing bleeding. So basically, in order to understand how it works, we first need to understand what fibrinolysis is. So fibrin is this non-globular protein that forms nets over bleeding sites in order to manage bleeding. So it forms these nets and it stops blood exiting the body by holding it in, basically. But these clots need broken down, and actually fibrinolysis, the process of breaking clots down, is really important in the body in order to make sure that the vascular system stays patent, because obviously clots in other areas are not necessarily a good thing. So this is mediated by TPA, which is tissue plasminogen activator, and plasminogen. And when these bind together and bind to fibrin, they cause fibrin to break down into these fibrin degradation products. So TXA then is a synthetic analog of lysine, which is an amino acid, and it interferes with the clotting process, or it interferes with the breakdown or the fibrinolysis process by competitively binding to sites on fibrin. Now, there's 6 binding sites on fibrin, and TXA binds to 5 of them, but they're all specific for plasminogen. So TXA kind of slots itself in and stops the plasminogen binding to the fibrin, therefore stopping the breakdown process. So I'll try and draw that for you here. Unfortunately, I'm not great at drawing. Maybe I'll improve by the end of the course. So we have a fibrin net, and we have the tissue plasminogen activator on the left-hand side, and then you'll see plasminogen here on the right. So normally they bind together in order to activate the fibrin. TXA, like I say, inserts itself here and stops this breakdown process. Now, possibly shown a little bit better in the diagram that I'm going to put up in a moment. As tissue injury, plasminogen and TPA kind of mediate this breakdown of fibrin, and TXA kind of inserts itself in the process, but TPA, along with plasminogen and plasmin, are kind of implicated in not only bleeding and coagulopathy, but in inflammation processes as well. So TXA does have some anti-inflammatory actions, but mainly we're giving it in order to stop this breakdown of fibrin. TXA is actually very well tolerated, so the risk of sort of thromboembolic events with TXA has traditionally led to some caution in its use, but recent studies suggest that actually the concerns might not be justified, and the earlier that we give TXA, according to very recent studies, the better the outcome. So it's actually a very effective drug in the management of trauma and severe bleeding. So in order to kind of further your understanding of TXA, I highly recommend that you have a read of the CRASH 3 trial, which was published in 2019 in The Lancet, and this looked at death, disability, occlusive events, and other morbidities in patients with acute TBI. And this is a really good example of a randomized controlled trial that came up with some really interesting suggestions about how quickly we can give TXA, or how quickly we should give it. So CRASH 3 kind of concluded that not only is TXA safe in patients with TBI, but that we should probably give it as soon as is possible. I've linked a few of these papers on Blackboard. Maybe take a moment to read them. There's quite a lot of evidence out there to suggest TXA is not only very safe, but the quicker we give it, the better the outcomes. But then we have to balance how quickly we give TXA with our other treatment priorities as well. So GR Calc at the moment supports giving TXA en route to hospital when appropriate, because we have to give it over 10 minutes unless the patient is in cardiac arrest. So lots of things to mull over there. Now, when it comes to your treatment priorities, and again, we'll look more at this when we come to part 2, but it's worth looking at now, I would recommend that you have a look at the patient group direction. So this is our PGD for the supply of tranexamic acid. And you can see from this that in terms of the criteria for inclusion, the patients that can be treated with TXA, these are patients who have had trauma with significant external or internal hemorrhage. We've had to use advanced hemorrhage control equipment, pregnant women who've had a traumatic injury, or patients who are in traumatic cardiac arrest. And even the PGD suggests that we should give it as soon as is clinically possible, and certainly within 3 hours of bleeding starting. We now also have an indication for head injury and for postpartum hemorrhage and obstetric emergencies. So worth having a read. These are all available on Blackboard, or they'll be available through the @SAS PGD interface for you to have a look at. So very much recommended. Okay, so let's review one more drug, and then I think we'll let you loose and let you review some drugs on your own. So I'll give you a list of the medications that are in the pouches, and you can kind of do some of your own work in terms of looking at the PGDs or GR Calc and looking at the mechanism of action, and I'll get you to post your findings to the Padlet wall so we can kind of collaboratively look at all the learning together. You might have noticed already, a lot of this course we do have a fair chunk of contact time, but a lot of this course is all about self-directed learning. So using the resources provided through the library and through textbooks, you'll be able to glean loads of information that'll be better than listening to me for hours. Okay, so let's have a look at atropine sulfate. Now, atropine comes in a pre-filled syringe, and the pre-filled syringe has 1 milligram in 5 milliliters. So what is atropine? What do we use it for? Let's have a look into that. So atropine, originally synthesized or extracted from the plant Atropa belladonna in the early 19th century, and you would know Atropa belladonna probably better as deadly nightshade. So it's a tropane alkaloid, and it has a half-life of sort of 2 hours. It is brought into the bloodstream in about 30 minutes to an hour, unless it's given intravenously, where it has a bioavailability of 100% for obvious reasons. And in general, what it does is it counters the sort of rest and digest activity that's mediated by our parasympathetic nervous system. Now, we've not talked about divisions of the nervous system yet, but we will in a couple of weeks. But all we really need to know is that it competitively antagonizes muscarinic acetylcholine receptors. Now, acetylcholine is the neurotransmitter that is responsible for mediating this parasympathetic nervous system, or responsible for facilitating it. So it competitively antagonizes these receptors, and therefore we call it an anticholinergic drug. So in our application, it works as a non-selective muscarinic acetylcholinergic agonist, which is lots of big words. But basically what it does is it increases the firing rate of the sinoatrial node and conduction through the AV node. It opposes actions of the vagus nerve because it regulates it counters the action of the parasympathetic nervous system, so it allows the sympathetic nervous system to take over, and it blocks acetylcholine receptor sites. So this means that it will increase heart rate, basically, along with a few other things, which we'll talk about in a wee second. Now, 60% of it is excreted in first pass metabolism, but generally it comes on pretty quickly within that 30 minutes. So why do we give it? Well, in our practice, we're going to give it for symptomatic bradycardia. So this is patients who have a heart rate of less than 40 BPM and patients who are hemocompromised. So those that have a systolic blood pressure of less than what is expected, or signs of inadequate perfusion along with their low heart rate. Now, it is used in ophthalmology to dilate pupils, and it can be used in combination with pradeloxime as an antidote for organophosphate poisoning, and we'll talk about that a little bit in toxicology. But it does have some other uses, so be aware of those uses as well, but mainly you're going to use it for symptomatic bradycardia. Now, what I want you to think about, just a bit of critical thinking required here, is we shouldn't give it when it's unlikely to work. Now, I've given you one answer there. So hypothermic patients are bradycardic because of a reflex effect, not because of a parasympathetic innervation. So atropine won't be effective. What other patients might it not be effective in? If we think about how heart rate is mediated by the vagus nerve, then if the vagus nerve is absent or has been cut or transected, then atropine isn't going to be effective either. So patients who have had a coronary artery bypass graft in the past, atropine will not be effective on those patients. And actually, think about it, patients that present with symptomatic bradycardia might often be patients who've had a heart bypass. So just worth thinking about. In that case, would you still give atropine even if you knew it wasn't going to be effective? It's just something for you to think about for the future. So the dose then is 600 micrograms IV, repeatable every 3 to 5 minutes, and you'll find that in GR Calc. So let's give you a few more paramedic drugs and their very brief mechanisms of action. So we carry adrenaline, 1 in 10,000. This is the same as any other concentration of adrenaline, but obviously this is more dilute than the 1 in 1,000 adrenaline that we carry for anaphylaxis and life-threatening asthma. Now, epinephrine, adrenaline, you're going to hear those terms interchangeably. In the UK, we refer to it as adrenaline. The Americans refer to it as epinephrine. In some chemical textbooks, you'll find it referred to as epinephrine, but try and stick with adrenaline when you can. So adrenaline is a naturally occurring hormone anyway, but we use it as a medication because it is a non-selective agonist of all adrenergic receptors, so the alpha, the beta, and the other ones. So this means that it increases heart rate, contractility, conduction. It increases respiratory rate and causes bronchodilation. In the liver, it stimulates glycogenesis, etc., etc. It is a very effective drug, positive chronotropic, inotropic drug. When do we give it? Well, we give it in cardiac arrest, 1 in 10,000, in order to provide some positive inotropy. So it comes as a pre-filled syringe for cardiac arrest. Remember not to confuse it with adrenaline 1 in 1,000. This is something that happens fairly infrequently, hopefully, but very dangerous to get the two confused. Indicated for cardiac arrest, and it's the 1 milligram in 10 mils every 3 to 5 minutes. The next one then, amiodarone. This is a class 3 antiarrhythmic, which prolongs the cardiac action potential because it's a potassium and calcium channel blocker. Now, Laura talked a little bit about potassium and calcium channels yesterday, so this should make a little bit of sense to you. But essentially what it does is it prolongs the QT interval. Because of the prolongation of the QT interval, it can cause bradycardia and bronchospasm. But that's not a concern to us because we only give it in cardiac arrest in shockable rhythms after the third shock, and we give 300 milligrams in 10 mils in a pre-filled syringe. All right, guys, so we've looked at the paramedic drugs that we carry. We've had a quick review of the indications and the presentation by looking at the pouches. And now we've looked at 2 drugs in a little bit more detail. We've looked at TXA and we've looked at atropine. So hopefully that helps your understanding of the term mechanism of action. We've already talked about pharmacology, pharmacokinetics, pharmacodynamics. So hopefully you'll be feeling a little bit more informed. Now, if you're feeling a bit lost, I have linked to some more learning resources on Blackboard. So there's some YouTube videos, there's some chapters out of books that you can use to further your learning a little bit if you feel like that'll be helpful. Now I'm going to pass the baton over to you guys. So I'm going to put a list of paramedic medicines here, and I want you to pick a couple, 1, 2, 3, it's up to you, however much time you have. You're more than welcome to do all of them if you really want to. But what would be great is if you look into these drugs, look at the mechanism of action. How do they work when we're talking about our specific therapeutic use? So for example, atropine used for other things than symptomatic bradycardia, but we're going to look at the use case for us and post it on the Padlet wall. Okay, tell me what the drug is, tell me what the mechanism of action is. And this method of peer learning, this has worked great in previous cohorts in that everybody will get to see what everybody else is posting. There are no penalties for wrong answers. If you put the incorrect thing in, don't worry about it. But it's really useful because hopefully by the end of that exercise, we will have a list of all the paramedic medications and their mechanism of action. If there are any missing, I will fill in the blanks. So if you guys could crack on with that now, and then after that, there is a video on toxicology for you to watch when you're ready. Thank you so much for your time, and I'll speak to you in a little bit.